Assalamualaikum. Today starting with a very important topic which is ovarian cyst, and it has two parts: the presence of ovarian cyst in premenopausal females and the presence of ovarian cyst in postmenopausal females. And I have divided first part into two halves, that is management of ovarian cyst in premenopausal women. Today we will be discussing its part 1, which will be covering the important history points, examination and investigation, and the management will be discussed in the next part. Are taken from Green Top Guidelines 62, that is for ovarian cyst in premenopausal females. So starting with discussing few statistics. 10% of women undergo surgery for ovarian cyst once in lifetime. Incidence of ovarian malignancy in premenopausal women 1 in 1000, while at age of 50 years it is 3 in 1000. 10% of suspected ovarian masses are found to be non-ovarian in origin. This means if one of us suspect an adnexal mass to be ovarian mass, but it could be non-ovarian in origin in 10% of the cases. 20% borderline ovarian tumors appear as simple cyst on ultrasonography. Rest have suspicious features. Okay, so these were the statistics. Now, what important questions to be asked in history? A woman comes with complaint of heaviness, bloating. She can come with complaint of constipation, increased urinary frequency, or some kind of menstrual irregularity, abdominal distension. Any of the complaint could be there, and sometimes only pain. So you have to ask certain important questions. Symptoms could be deep dyspareunia, dysmenorrhea, infertility, abdominal distension, loss of appetite. Means mostly in most of the cases she comes with loss of appetite, not increase in appetite. Pelvic or abdominal pain, increased urinary frequency, urgency, because the ovarian mass or uterine mass, they just press over the urinary bladder. So the urinary complaints are very common in these patients. Acute abdominal pain, keep in mind torsion, rupture and hemorrhage. Okay, so about examination, what important examination has to be performed if a woman comes with complaint of abdominal distension or any of the symptoms we have discussed in the previous slide? The examination performed should be abdominal and vaginal examination. You have to assess during abdominal examination the size of the mass, whatever we know about the principles of examining a mass, its size, site, if it is tender or not, its temperature as compared to the surrounding skin, and its relation to the uterus, whether it is arising from adnexa or connected to the uterus. This will most probably be assessed in vaginal examination, and its association with the pain, radiation of pain. So all these things. You have to assess mass tenderness, its mobility, nodularity and ascites. All of these things are mostly associated with malignant ovarian masses. Presence or absence of local lymphadenopathy, you can assess inguinal lymphadenopathy easily. However, aortic lymph nodes could not be assessed. Sensitivity of clinical examination. So we comment that the accessible lymph nodes are not palpable. We never say that the lymph nodes are not palpable. Which lymph nodes are not palpable? That are the accessible lymph nodes. Sensitivity of clinical examination is 15 to 51%. Okay, so these are the types of adnexal masses. If we talk about benign ovarian masses, they include functional cysts, endometriomas, serous cystadenomas, mucinous cystadenomas, and mature teratomas. In benign non-ovarian masses, paratubal cyst, hydrosalpingus, whatever structures are present in the adnexas, they can include appendix, diverticular abscess, pelvic kidney, tubo-ovarian abscess. These are the benign non-ovarian masses. And primary malignant ovarian mass, germ cell tumor, epithelial carcinoma, sex cord stromal tumor. Their origin is the ovary. And secondary malignant ovarian are predominantly breast and gastrointestinal carcinoma. The gastrointestinal one, we call it Krukenbach's tumor. So these are the important tumor markers. If we assess alpha fetoprotein, so in what tumors it is raised? It is raised in if suppose yolk sac tumor is present, immature teratoma, embryonal carcinoma, and Sertoli Leydig cell tumor. So they are associated with alpha fetoprotein. For beta hCG, the tumor markers, for this tumor marker, the important carcinomas are choriocarcinoma, embryonal carcinoma, and dysgerminoma. LDH is associated with only one, that is dysgerminoma. For C125, epithelial tumors, and inhibin is raised in cases of granulosa cell tumor. So this is very important. This question can be asked in Viva or during bcqs as well. So you have to learn, or you should know, about all these tumor markers and their associated carcinomas. Okay, so what blood tests are important and when? So if there is simple ovarian cyst in women under 40 years of age, there is no need to perform C125 because it is very rare in this age females that C125 would be raised and they would be having epithelial ovarian carcinoma. But if complex ovarian cysts are present under 40 years, then C125 is also measured. Other than that, most important ones are LDH, alpha fetoprotein, and hCG because they are associated with germ cell tumors, and in this age group they are very common. Okay, so if we talk about raised CA125 differential diagnosis, that in what cases it could be raised other than epithelial ovarian carcinomas. So CA125 could be raised if there are fibroids, endometriosis, adenomyosis, pelvic infection. So these are the things, these are the conditions in which it could be raised, but its level is not up to that which is compared in malignant ovarian masses. If raised but less than 200 international units per ml, consider other differential diagnosis. Like it would be raised more than 35 but less than 200 in these conditions. If more than 200, refer to gynecological oncologist. Most probably it would be ovarian carcinoma. Fast rising levels of CA125, there is likely possibility of malignancy. So this is very important. If suppose in exam it is given that it comes as 100 international units per ml, what would you do, what will be your next step? So you will definitely consider other differential diagnosis as well. Okay, so what investigations are important? Pelvic ultrasound scan, in which transvaginal scan is the preferred one because it can easily diagnose the adnexal masses. Most probability is more than the transabdominal scan. However, if there is presence of larger masses and if you are suspecting some extra ovarian disease, like you want to see kidney pathology as well or some kind of intestinal pathology as well, then you should go for transabdominal scan. And for CT scan and MRI, there is no final consensus, like they are not said to be proved very important in case of diagnosing any kind of adnexal pathology and ovarian carcinomas. Okay, so risk of malignancy index, very important, and how it is calculated, everyone should know. RMI is calculated by multiplying the ultrasound scan score from the status of menopause, like if the female is premenopausal or postmenopausal, and the level of CA125. So for ultrasound score, for these conditions, each condition it scores 1 point. One for multilocular cysts, one for solid areas, one for metastasis, one for ascites, one for bilateral lesions. So suppose if two of them have got 1 point, then it becomes 2. And if the score is 2, then the ultrasound score is 3. So we will write 3 here. So it depends on how much one has scored in these areas. Like if all is 0, then the score would be 0 and ultrasound score would also be 0. But if one of them has got 1 point, like if ascites is present and nothing else, the score would be 1 and ultrasound score would be 1 as well. If 3 of them have got 1 point, then score would be, points would be 3 points. And if we look here, then from 2 to 5, the ultrasound score is 3. So 3 also comes in between 2 to 5, so the score would be 3. So that is how we calculate these scores. Now for the menopausal status, in premenopausal the score is 1, while in postmenopausal directly the score becomes 2. And for CA125, whatever level comes, suppose if it is coming 150 and the female is postmenopausal, so 150 multiplied by 2, and then it would be multiplied by the ultrasound score, so the final result will come. Okay, So apart from calculating RMI, there is another ultrasound based assessment for diagnosing or differentiating between benign and malignant ovarian masses. This is known as IOTA simple rule assessment. For IOTA rules, there are certain rules, like for malignant tumors, they are known as M rules. The M rules include the malignant tumor would be irregular solid tumor. It would be they would be having presence of ascites. There would be at least 4 papillary structures in the ultrasound. Like if you have performed ultrasound scan, then the ultrasound report will be showing that there is an adnexal mass which is most probably ovarian origin, and it has 6 to 7 papillary structures. So for the mass to be malignant, it should have at least 4 papillary structures. The fourth point is irregular multilocular solid tumor with the largest diameter greater than 100 mm. This means that the mass which is malignant, it should be irregular solid tumor and its largest diameter should be greater than 100 mm. Very strong blood flow, color scope 4. So these are the points for malignant ovarian tumor. While if we discuss benign, then for benign the rules are unilocular cyst, presence of solid components where the largest solid components has a largest diameter less than 7 mm. So the diameter is very different. Like here would be greater than 100 mm and here it is less than 7 mm. Presence of acoustic shadows. A smooth multilocular tumor with the largest diameter less than 100 mm. So it is a smooth tumor, it is irregular multilocular solid tumor, its diameter is less than 100 mm, it is more than 100 mm, and no blood flow. So these ultrasound findings can also differentiate between benign and malignant ovarian tumor. So apart from RMI, these are also the diagnostic tools. So thank you so much for today. In the next lecture, we will be discussing the management of ovarian masses in premenopausal females. Thank you.